This is the video of a left-sided stapedotomy or stapes surgery, where the plan is to use carbon dioxide laser for the surgical procedure and to use the titanium soft clip piston for the ossicular prosthesis. As you see here, we are using a microscopic approach. You can use either the microscopic or the endoscopic approach. I'm pretty comfortable using a self-retaining organ speculum, which has been fixed into place. The fact that the speculum fits into place obviates the need to constantly hold the speculum with one finger. You might need to use it for a single step like curating, as you see so. The tympanomeatal flap has been raised. One must be cautious while raising the flap in a thin tympanic membrane. And as you see, after some amount of curating, that sometimes could lead to fatigue. We're using a curved diamond burr to remove some bit more of the scutum, as probably you all understand that the left side, the scutum remover is slightly more as compared to the right side. We really want to prefer to see the most of the fallopian canal, the height of it, and to see the pyramidal process. This sheathed burr helps us drill this bone conveniently without any flap trauma. Now, once we have done that, we check for the ossicular mobility to find if the stapes is indeed the only ossicle that is fixed. One can have a pan-ossicular fixation or the incus fixation, malleus fixation. So we see that how the incus is moving, the malleus is moving, but the stapes is not moving. The fallopian canal is well visible, and now we are using a right angle pick to separate the incudostapedial joint after finding the correct plane of doing so. Also, I think one can appreciate that this is a favorable sort of situation in terms of the kind of foot plate we see. It is not does not appear to be a thick, sclerotic biscuit kind of foot plate. It seems to be a reasonably simple situation. We can see the round window niche from here, the glistening blue colored oval window, and the stapedius tendon right in front of us. Now we'll focus our laser shot onto the stapedius tendon. Here we are using 8 watts setting on a spot configuration, and you can see how one must be careful of not to overshoot or shoot on the foot plate. One must also evacuate the smoke while using the laser, and the one can use microbipolar forceps or simple scissors. The laser helps us achieve hemostasis with the stapedius tendon. So you see on 8 watts, it also depends on the depth settings that you have kept. I think here we have kept around 1 as the depth setting. So we have required 2-3 shots to fulgurate or vaporize the stapedius tendon. And at the same time, we use the suction to clear out the smoke from the middle layer. Now, once we do that, we come to the stapes head, and we need to remove or fulgurate the posterior crura as well. Again, this step can be done either using a skeeter drill, or sometimes one may fracture the whole head. Now we have taken down the stapedius tendon and the posterior crura, and now you see we fracture this stapes head right here and getting the anterior crus removed. So it's always a good situation doing so and causing least trauma to the foot plate. Now we focus our attention towards the foot plate proper. Our spot size here is 0.5 millimeters because the piston we want to use is 0.4. And once we clear the blood, we focus on the somewhere between the middle and the posterior portion of the foot plate. The settings is 20 watts here. And here, mind you, we only want to use a single shot, not multiple shots, as they can create a very large opening in the vestibule. You see that the opening on the vestibule is already created right where we wanted, and that's to our comfort of 0.5. And you see that how atraumatic this step using the carbon dioxide laser is, which is immediately followed by using a piston. We had measured this before. The distance was 4.25 to the foot plate, and adding 0.25 as the depth of insertion. inside the vestibule, we use a 4.5 length soft clip titanium piston. Once you see as it has been placed on the stapedotomy, now we don't need to officially crimp it using a crimper because that moves the incus too much. Here we'll just use a sickle knife or a right angle pick to just glide this, and using a self crimping mechanism on the incus. You see here how simple this is. By a simple flick, a control flick, this self crimping or soft clip piston just goes on to clip onto the incus, and using a very thin 24 suction to clear off the collections of the blood here around it, and we must avoid any direct section on the vestibule or on the open vestibule. Once you've done that, you move the incus and see for any play in the assembly. There's none, so it is well set. There is some blood on the vestibule, and that seems to be good enough to create a soft seal onto the junction between the vestibule and the implant. So once the piston is nicely crimped, it's time to put our flap, tympanomeatal flap back after switching off the laser. This is a transcanal approach. So once you put the flap back, we put some gel foam, dry and antibiotic squeezed in on the EAC side. We don't put any gel foam in the middle layer. That is the chorda tympani. As you can see, it was placed slightly inferiorly, and now the flap would be placed back. You can see how the malleus movements are nicely transferring onto the crimped piston.